Hi, everyone. My name is Zara, and today I'll be presenting my findings from my study, the relationship between socioeconomic status and variability in hospital pricing for elective joint arthroplasty in New York State. The background. In 2019, CMS mandated that hospitals post pricing data for shoppable services like orthopedic surgeries in machine-readable files. The idea behind it was to improve patient financial planning and decision-making. However, there's been mixed results, especially for the lower socioeconomic status community. There's been poor usability and limited patient engagement. What's the importance for low socioeconomic communities in this analysis? As we know, there's an equity gap that exists in healthcare access. That gap exists in pricing transparency as well. Patients from low socioeconomic status communities are more dependent on hospital-provided care. They are less likely to go to ambulatory surgical centers for orthopedic care, making hospital pricing data more critical for them. Unfortunately, we know they also face more barriers in accessing and understanding the data that's provided in the machine-readable files, as they have poor digital and health literacy, and they're less likely to have access to internet. And we also know that they're more sensitive to hospital financial costs, especially out-of-pocket costs. The main objective of my study was to examine whether hospitals in low socioeconomic areas show more pricing variability for lower extremity elective procedures such as total hip arthroplasty and total knee arthroplasty when compared to high socioeconomic status hospitals. For our methods, we looked at 3 socioeconomic status indicators: percentage with bachelor's degree or higher, percent of insured population, and median household income. We ranked each county by education, insurance, and coverage and income to create a composite socioeconomic status score. Then we ranked the composite scores. For example, if a county got a rank score of 1 in education, 1 in insurance coverage, and 1 in income, it would get a total composite score of 3. Whereas a county that ranked at the bottom for each of the 3 indicators at 62 would get a composite score of 186. This allowed us to rank the 15 highest and the 15 lowest socioeconomic status counties and compare the 2 groups. For our hospital inclusion criteria, we focused on hospitals that perform total knee arthroplasties and total hip arthroplasties and excluded those that were multi-system hospitals, single specialty hospitals, children's hospitals, VA hospitals, and hospitals that failed to provide any pricing data in form of machine readable files on their websites. Our results showed that low socioeconomic status counties had significantly lower income and education and insurance coverage factors known to impact healthcare access and literacy when compared to high socioeconomic status counties. In terms of hospital pricing variability, our data showed that there was no statistically significant difference in the pricing variability among the groups. However, the access was clearly skewed among the socioeconomic status groups. There were only 14 orthopedic hospitals that served low socioeconomic status counties compared to 25 in high socioeconomic status counties. Some rural counties like Hamilton and Essex that cover a vast geographical area only had 1 hospital serving the whole county. For comparison, Bronx, which has a much smaller geographical area, has 5 different orthopedic hospitals serving it. We also found that of the 6 hospitals that failed to provide machine-readable files, all 6 of them belonged to low socioeconomic status groups. What are the policy implications of this? While pricing differences weren't significant, access and transparency evidently still need need improvement. Hospitals in low socioeconomic status areas fail to adhere to the federal mandate at a much higher percentage than those hospitals in high socioeconomic status areas. So federal government should consider better enforcement and regulations by introducing higher financial penalties for noncompliance and then withhold federal funding for continued noncompliance. And although it's very unlikely to happen, the more important step would be for the federal government to regulate negotiated insurer rates and total out-of-pocket costs to give patients full pricing transparency, which we know is the most important data point for patients. And more importantly, our data showed that pricing transparency by itself does not address structural inequities that exist, or that already exist. To make pricing transparency meaningful, we must address the current socioeconomic inequities. For example, transparency is not effective without improving accessibility and option. If there is just one hospital serving a whole county, then patients are not able to shop around for services. They're limited to that one hospital for the services that it provides. We know that low socioeconomic status areas lack both accessibility and options. So in order to address that inequity, that needs to be addressed first and foremost. And in the future, research could look at a more granular level using census tracts and zip codes, and utilize better coding tools to automate data extraction and examination of these large data set files for a more precise analysis on these machine readable files. Thank you.